prevent those children from becoming those adults with sleep apnea eventually.
Hey guys, welcome back to Dental Dork. Today's video is a recording of an interview I had the opportunity to have with Dr. Joe Gaudio. He's a dentist who's located in New Jersey and has been studying airway dentistry for a number of years now. The interview is primarily on children and sleep disordered breathing, how it's related to TMJ, how it's related to sleep apnea, and how all of this kind of develops at a very early age. I have included some timestamps below in the description so you can kind of skip to whichever part you're interested in. And before we begin, if you guys could click subscribe below and click the little bell to get more notifications. I hope you enjoy. We'll start off with an introduction for our audience of who you are exactly. You are Dr. Joe Gaudio, my childhood dentist, which is just wild. And I guess I kind of went off into my professional career, and my mom contacted me after coming in to see you at some point and was like, hey, I saw Dr. Joe Gaudio today, and he started talking about some of the similar stuff that you were telling me about with airway focused dentistry. And that's when she was like, you should totally give him a call. And so I did, and that's when we had our very first conversation, and I was like on cloud nine after we got off the phone. I was like, oh my gosh, his knowledge, it's so amazing. Then we had a couple conversations since then, and I was like, I've got to record this for, my channel and anybody to watch and see. So I was let's just get you here.
At that point, did I give Mom a copy of the book at that point as well?
Yes, your book. I think she mailed it to me.
Well, I got to tell you, we may have touched upon this, but the reason for the book was just the fact that people kept coming in and kind of scratching their heads like, what are you talking about? I've never heard any of this stuff. Mm-hmm. How come my pediatrician has never said this? How come my orthodontist has never said this? Why is it that you're talking about this and they're not?
Right.
And I think what has happened is that a lot of moms now are actually looking for, how do I help my child?
Right.
I'm at a loss. I keep running into walls, or I'm told all the time they'll outgrow it. Mm-hmm. And you've got parents who find themselves just frustrated because it's years and they've still not outgrown it.
Yeah, quote unquote, wait and see.
So on that note, what I wound up doing is, again, my background at this point was, at that time, 30 years of restorative dentistry, always focused on, occlusion, restorations, of course, TMJ as a result of that as well.
Yeah.
The TMJ kind of got me more involved with the hospital that I'm over at Morristown as an attending. And the more and more I got involved with the oral facial pain, TMJ, the more it was like, well, wait a minute, most of these patients actually suffer from airway issues. Mm-hmm. The high vault, they're having, all kinds of problems. And the more I learned and the eyes that you develop about what to look for, as we say, once we see it, we can't unsee it. Mm-hmm. So you start looking at these credentials of a tongue tie, of a high vault, of collapsed jaws, and very, very crowded and constricted. Upper jaw, of course, always being what we say, the upper jaw is the criminal.
Yep.
The lower jaw is always the victim. So when you trap that lower jaw, you basically get the jaw joint to go back further, compression, headaches, you name it. I'm like, wait a minute, this is all kind of tying together. Mm-hmm. So then I got introduced to the children's airway stuff through a friend and mentor of mine, Dr. Ben Moralia, who had been treating children at that time for about 16 years.
Oh, my word.
And the first time I heard this presentation, it just blew me away. Mm. And I said, wait a minute, something's going on here. Made a real connection with me because my son, who was tongue-tied, and we didn't know it until 9 months. And for 9 months, nobody slept. He was up, all night. He basically tried to feed every hour and a half. He was incredibly colicky, etc. All these things just kind of came to mind. And after 9 months, we finally said to the pediatrician, yet once again, what's going on here? And he looked in and went, oh, look, he's tongue-tied. Snip.
It's that simple.
And I wanted to kill him.
I'd imagine.
Wanted to hit him over the head with a 2x4, but worse yet, I was embarrassed by the fact that, wait a minute, I'm a dentist. There's a tongue, there's a mouth here. What's going on here? I mean, I'm not a pediatrician.
Sure.
So I kind of backed off a little bit on beating myself up, but I realized how this all related.
Is that kind of where it all began for you?
So for me, again, all of a sudden I was on fire with this stuff, made that connection. My wife, who has been having sinus issues her entire life seasonally without doubt, she just never misses it. It's like a schedule thing. And about 3 or 4 years ago, and now this was 5 years back, she had developed a sinus infection, which was treated twice with antibiotics, final third round of antibiotics with steroids. And I started looking at all the credentials there. She was 4 premolar extractions. She had headgear on for 5 years as a child to correct the buck tooth because they were too far forward.
Yeah.
The case, as we know now, right?
Right.
So all of that really got me on a tear. And I just started with a 2-year ortho program for GPs. Then I went to the Airway mini residency. Then I went for all the myofunctional stuff. Then I went for Dr. Galella's course, Bill Hang, courses online with him, and on and on and on and on. And it's just never stopped. Constantly trying to learn, constantly trying to have more tools in the toolbox to be able to treat children, young adults, and people who are suffering with, outright sleep apnea.
Yeah.
So it really has become something that, for me, it's become a passion. I love my dentistry. I love my restorative dentistry. But honestly, I finally found what I wanted to do when I would grow up. And this is it. In terms of being able to change lives and prevent those children from becoming those adults with sleep apnea eventually. Not on my watch, hopefully.
Yeah, it's so profound what an impact you can make if you start young on those kids. What is the earliest time that you are able to identify an issue? I want you to elaborate a little bit on where those signs begin.
Parents who have infants, unfortunately, don't always have the proper guidance, but in terms of attempting to breastfeed, right out of the gate, if there's any difficulty with breastfeeding, if there's any challenges at all where mom is uncomfortable, or if it's painful, or if the baby just can't latch on properly and has a lot of struggling with colic and so on and so forth, usually means that there's not a good seal with regards to the baby latching on. Backing up a little bit, in terms of in utero, there are 2 people specifically, a Dr. Kevin Boyd and a Dr. Mariana Evans out of the University of Pennsylvania, who are actually looking at ultrasounds in utero, and they're looking at, if they can get a profile, they're looking at credentials. So again, a receded chin in terms of the facial convexity and so on, so that when that child is born, we know that there's risk factors there. So now let's look and see what happens after birth. Again, in utero, we touched upon this a little bit the other day. By the 35th week of gestation, we learn how to swallow by swallowing amniotic fluid. So that helps to train that swallowing reflex and get that going. By about 38 weeks of gestation, we learn how to stick our tongue out. And so if children are born prematurely, gotten to age in utero, have they missed out on that training for these muscles? Potentially, has that kind of caused a tethered tongue or a tongue tie? Who knows? Really not sure what the origin of that is, if it's genetic, if it's epigenetic, etc. But there's an opportunity there to really see whether or not there's a problem.
Being in utero still, there's always babies even like sucking their thumb on ultrasounds and stuff. What are your thoughts on that? Is that because there's already a deficiency, or is it?
Well, as far as the thumb sucking, there's definitely a neurological component to that in terms of the stimulation of the palate. So the palate should be stimulated by the tongue. If the tongue lives in the roof of the mouth and it lives behind the upper front teeth, and that swallowing reflex in terms of what we call the peristalsis, which is that wave of muscular contraction that occurs to bring the bolus of food down to, through the food tube, that starts. So that stimulation is on the soft palate. When the tongue doesn't live in the roof of the mouth, we're looking for substitutes. And the thumb is going to be, or fingers even, is going to be a good substitute for that child. In utero, these again maybe could be primate needs that we have that are just something that we're looking for. And all of those muscles are not developed as of yet. But as an infant, if we wind up having that lack of stimulation, there's a neurological connection from the soft palate to the pleasure centers of the brain and dopamine release and serotonins and so on and so forth that we need to have. When an infant breastfeeds, breastfeeding is what trains the tongue.
Is there anything else? Is that the only thing that trains the tongue?
I'm going to tell you, unless there's a myofunctional therapist around.
Right. It's exclusively breastfeeding.
Yeah, so what happens with breastfeeding is this. In terms of breastfeeding, latch on, complete seal. If we're not getting that seal, tongue tie and lip tie is what we look for.
Yep.
If we can't get a seal, we're going to be swallowing air. If we swallow air, we're going to have gas. And it's going to come out of both ends because it's not comfortable. So a child that's struggling with that, look for lip ties. So sweep, for the moms out there, sweep your finger under that upper lip. And if you feel a little rubber band that kind of stops you from sweeping back and forth without any resistance, that could be a lip tie.
Yeah.
And under the tongue, same thing. Just sweep the floor of the mouth. And if the tongue doesn't lift, if a child doesn't stick their tongue out, an infant should stick their tongue out without any resistance.
Right.
If you never see the tongue, it's probably tied.
Okay.
So then getting back to how the tongue is trained as the muscle that it needs to be, the tongue compresses mom's nipple on the roof of the mouth.
Right.
It doesn't suck milk out of the breast. There's compression, and then when it's released, there's a vacuum, and that's what pulls the milk out of mom's breast.
Yeah.
So that compression that occurs on the roof of the mouth is what expands the upper jaw. When you expand the upper jaw, you also grow the midface.
Right.
When you grow the midface forward, outward, and downward, the back of the midface is the airway. And so everything, form follows function. If we don't use it, we lose it. So we need to have all that going into play. An infant is an obligatory nasal breather. They latch on, and they can breathe through their nose while they're feeding because of the way the soft palate and the epiglottis, or the little flap that covers the food tube, the way that comes together at that time in life is what allows that infant to breathe through the nose while feeding. As the months go by, that starts to separate, and you start to get a lowering of our voice box. The fact that we have a voice box is what complicates this, because in animals, you don't have an issue.
Right.
Okay. In humans, as we get older, that descends. Now we've got a space in between that can cause us to get food down the air tube and air down the food tube.
Right.
So that's the issue. But as far as the training of that tongue, it's that compression, that expansion that occurs that allows that tongue to be the muscle that it needs to be.
So for mothers that either choose to or can't breastfeed and end up going right to bottles, that child's already just set up. That tongue never learns how to be properly used, is what ultimately is.
So the problem with trying to replicate artificially mom's teat is the fact that regardless of what material you make it from, you just cannot reproduce that nipple with the different ducts inside of it, multiple ducts that allow for that expression of milk.
Yeah.
So usually it's a hard rubber nipple, and the tongue finds that it's in the way. In the first days of life, just like we know that a baby's head is soft, so is the rest of the head and neck area. And that nipple, if it's forced upward, can actually cause the vault to get higher. It can actually cause a nasal septum to deviate, even at that early age.
Wow, okay.
So that's in the way.
Yeah.
So if we don't go up, now we're going to learn how to tongue thrust.
Yeah.
And that's the problem with bottles, and that's the problem with pacifiers. So there are substitutes for the pacifiers. If you're familiar with any of the myofunctional appliances,
Yep.
the
Munchies,
munchies, the button, things of that nature can be used for training to correct bad habits. And then there are a couple of bottles out there that are intended to mimic mom's breast as closely as possible.
And what are your
but
thoughts?
There really is there's no substitute for that.
So how long is ideal? I know in our Western society now and culture, even if there is breastfeeding, it's for 6 months maybe to a year at typically most, because then it just becomes unacceptable in our culture. So what is the ideal time frame for an infant to learn that?
Yeah, so in non-industrialized societies, and these were studies that were done by a Dr. Robert Corricini, who's an anthropologist, and also there was a Dr. Weston Price, and this was probably back in the late 1800s, who traveled, that was Weston Price. Dr. Corricini is still with us, and he's been at it for probably over 40 years at this point.
Wow.
But they both went and looked at cultures that were isolated, non-industrialized, that basically mom had children, obviously breastfed. There were no boxed meals. There's no baby food and so on, and so they breastfed on average from 2 years to 4 years on average.
Yeah, that's what I heard.
Yeah,
it's a long time. I mean, that's just not comprehensible for so many women, and I mean, there's working moms and just the society, just the culture.
Yeah.
It's
what changed in our culture very dramatically was, of course, industrialization, but especially the world wars. When the wars came, the men were off fighting, and the women went to the factories to make the munitions.
Yeah.
And so there was not the time that they had previously to rear that child the way God had intended to.
Yeah.
No disrespect on any of the moms.
No, I can't.
And it's just the fact of a biologic, it's all biology.
What is typically the earliest time that like say allergies can come a factor, and with clogging the nose and having the tongue drop to the floor of the mouth at that point, what is that component of all of this?
Well, allergies can arise at any time. I mean, they can arise right out of the gate. When we talk to parents about what's going on with children who are obvious mouth breathers, okay, and the nose is made for breathing, the mouth is made for eating. We try to get that point across. I love this from the ladies who are teaching this pediatric program. Her usual line is, "You wouldn't eat ice cream through your nose, would you?" Right? So the nose is an incredible organ, as is the tongue. That can start in terms of going off track from day one if there are pets in the house, if they allow pets to be in the bedroom, if there's allergens, a new carpet because they had to get baby's room all set up for the new baby. We have all kinds of environmental issues that attack our bodies day in, day out. As we get older, the biggest component to that is actually the food that we eat, because of all the junk that they put in our food. It's horrific. But starting early on, again, I need to be cautious about saying that milk, causes nasal congestion. It could, but not necessarily is a problem. Honestly, cow's milk is made for little cows, not for little people. So in terms of, the best milk for a child, as we know, is going to be mom's milk, because of immunities, because of all the other benefits as well. But the allergies can be an issue immediately. If the room is too warm, part of our sleep hygiene that we always recommend is to make sure that the room is cooler. We want that room for sleeping to be honestly below 65. At home, we actually have our bedroom at 63.
Really?
And that prevents your nose from clogging up from the heat and from drying out.
Okay.
So you want to have moist tissues. The nose is made to filter and warm. The nose makes something called nitric oxide.
Yeah.
Nitric oxide is an incredible gas. We breathe and basically benefit from three gases:
Okay.
oxygen, carbon dioxide, and nitric oxide.
Mhm.
And nitric oxide helps to make all this stuff work properly so that we can exchange gases properly. Now, the other benefit of nitric oxide is that it kills viruses, bacteria, and dust mites. And in the environment that we're in today,
Right.
it's huge to make sure that you're breathing properly through the nose to filter out all these bugs that are out there. And of course, this new novel type
Yeah.
of virus that we
There
have.
was
But
actually, back in 2005, there was a study that was done on nitric oxide when breathing through the nose, how I think it stops the replication of the virus, of coronavirus specifically. Now, back then, I
well,
guess it was
that was
SARS.
SARS.
Yeah, it was
So the
SARS
first
1.
coronavirus that was out, or the first one of multiple
Sure.
coronaviruses. But when SARS came out, that study came out as a result of what was going on with
Right.
SARS.
At that time.
They did find that there was a decrease in infectivity rate because of that.
Right. Yeah, which
Okay,
is
now,
just mind-boggling, and you
oh,
can only hope that it would be applied to today's time with this new SARS coronavirus too. So it's pretty
well,
interesting.
keep in mind with this coronavirus, the one thing that was said initially is that the most susceptible people were your elderly with pre-existing conditions.
Hmm.
And then all of a sudden they found that there were younger people in their 50s and 40s and even 30s that were dying.
Yeah.
And so every once in a while they'll post a photograph of someone who's passed in a community. And I want you to look for the credentials there of airway issues.
Hmm. It's a great
Very
point.
large neck, usually obesity being an issue. Again, the shiners, the class 2, and so on. Those are problems that prevent us from breathing through the nose and using that nitric oxide for all the benefits that it gives us.
Hmm.
We're at a disadvantage because we cannot thrive without the nasal breathing and the proper growth of the face. So, getting back to our anthropologist, what he found was the problem in our society is that there's limited breastfeeding. He found that these communities, these cultures that were breastfeeding for 2 to 4 years, and that were also going from breastfeeding to food, not mush.
Yes, this is great.
So all baby food is mush.
Hmm.
Parents are very, very anxious about giving hard foods to children for fear that they'll choke.
Right.
And the problem is that if you don't use your muscles, you can't grow the bones.
Right.
Okay, so there's the functional matrix theory, and that means if you don't use it, you lose it.
Hmm.
So in order for us to develop a nasal passage, if air's not flowing through,
It's not good.
it's going to atrophy.
Right.
Okay, if we're not using our jaw muscles to chew, because everything is just mush, not good. So we want to be able to encourage eating vegetables, apples, carrots, non-carrots, and so on, and then transition to harder foods.
What would you say if you had to put a percentage on it? What percent of our population has some form of malfunction in either muscle movement or growth or development coming out the gate, like from infantry to early childhood?
So one of the things that Dr. Corricini did with his study is he basically looked at malocclusion or crooked teeth.
Hmm.
And when you look at all of that and all the, again, the credentials of the narrow arch, the crooked teeth, the buck teeth, the high vault, remember the roof of the mouth is the floor of the nasal passage.
Right.
So if the roof of the mouth is here, and here's our triangle where the air comes through, the higher that gets, the more constricted this is. We're constricting that nasal passage. It's going to reduce airflow.
Right.
So what Dr. Corricini found in part of his studies is, again, the limited breastfeeding, the lack of hard foods contributed to crooked teeth.
Hmm.
And what he found was that after the first generation of introducing soft foods and a processed diet and the lack of breastfeeding, there was a 50% increase in crooked teeth.
Really?
The second generation showed a 75% increase.
Oh, my word.
The third generation showed an 85% increase. So since we in our culture have industrialized, which is now probably 5 generations out, we've got probably about 90 to 95% of our kids who have crooked teeth.
Yeah.
And unfortunately, most orthodontic treatment waits until they have all their adult teeth, and we've missed the growth curve on that tremendously.
Yeah.
Okay, when you look at, and there was a study done with regards to sudden infant death. So they did a study, and it included about 7 infants that unfortunately had passed away. All the same credentials: high vault, narrow arches, tiny nasal passages as far as nostrils, or what we call nasal valves.
Yeah.
All those credentials were there. And most of them, unfortunately, wound up dying from a sequela of congestion, bronchitis, pneumonia, etc. And the credentials are there, just like they are from these adults that we see that are dying in their sleep.
Yep. It's all starting at the very beginning with these kids being so young, having malocclusion due from whatever factor it might be, allergies, lack of hard diet, lack of function or breastfeeding, and training that tongue, and leading into the top jaw, like you had said, kind of being the instigator and keeping everything small, not allowing the lower jaw to grow and develop, which is then shoving, kind of keeping that jaw back and not allowing the condyles.
Right, preventing for that growth to come forward.
Right.
Putting pressure back here. So one of the other things that for moms out there, I want you to really be aware of is tubes that have to be placed in the ears because of inner ear infections.
Yeah.
So normally that is a factor of a chin that's back, the lower jaw that's trapped, and the compression in that area, because there's very tiny space back there that compresses the eustachian or inner ear tube and prevents proper drainage.
Okay.
Tubes that are placed in these children may be very effective if they do them once. They lose most of their effectiveness if they've done them twice, and I'll never recommend anybody getting them done 3 times.
Wow.
One of the things that we do with children who have their baby teeth in place and are experiencing ear infections is to actually put composites or bonding material on the second baby molars so that there's some height to them. They're the ones that hit first, and what happens there is that you decompress that by pulling the jaw joint down. So by placing composite that they'll hit first on those second molars, it pulls that down, decompresses, and you're now draining the inner ear tubes.
So would that also, that young, be like a prevention for TMJ technique once you have that bite opened?
TMJ comes from
TMD.
These limitations, comes from being trapped as far as that lower jaw. So the way I like to describe this to my patients is, think of the lower jaw as being a door. Okay? The 2 hinges are here. The lower jaw swings up and down. Think of the upper jaw as the door frame.
Right.
If those jaw joints are out of position or the frame is not lined up properly, right? Yep. Everything has to be perfectly lined up.
Right.
So if the 2 hinges are off, the door's not going to fit in the frame.
Right.
If the frame is too tight, the door's not going to close evenly inside that and then put stress on the hinges.
So how come TMJ or TMD really becomes somebody's problem once they're an adult? Is there a trigger that really sets it off? I mean, because obviously as a child, it was kind of, they were growing and developing a way to be set up to have a disorder of the TMJ. But what is it typically that's like all of a sudden now they're having problems?
We're pretty adaptable as human beings. But at some point, our adaptability is exceeded by the stressors in our lives.
Right.
Okay? And then when there's chronic pain, then pain changes in terms of the neural connections. So when you have chronic pain, that level of adaptability disappears. In terms of the amount of stress, trauma that occurs, everything's magnified, and you do not respond as a normal person to chronic pain. During an acute phase of trauma, if we can treat with anti-inflammatories, even a Medrol, steroid pack, basically, things should return to normal.
Okay.
When things are chronically trapped, and or when someone's airway is constricted, the tendency is to move forward, right?
Yep.
So if patients come to see us for an airway issue and they were told you need to have a CPAP, I don't want a CPAP, I want an oral appliance.
Right.
An oral appliance is an anterior positioner. So a mandibular advancement device is an oral appliance, and so is bringing your lower jaw forward or posturing forward in order to open up the airway. So if your teeth are trapping you, you're going to wear the teeth down. If you're sliding forward and back constantly to open up your airway, you're going to flatten out the top of the condyle.
Right.
And you're going to see these changes over time. And people don't make this connection. Most patients say, I've got pain here, turn it off.
Right.
And it is not a matter of, oh, here's a switch, let me just throw that circuit breaker and you're done.
Yeah.
So what I've learned throughout this journey of mine, I always used to look at TMD as being an occlusal muscle issue and or trauma. But I didn't make the connection that we need to bring that lower jaw forward in order to open up the airway. So there's a gentleman by the name of Gerald Simmons. He is a sleep physician, neurologist, and also an epilepsy specialist. Well, Jerry Simmons basically demonstrated that if you have desaturation of oxygen, and he did this during a sleep study, he said, watch this. If I turn off the valve and turn down the oxygen, sorry, Jerry, if anybody comes after you for this, but if I turn off the oxygen on this person, watch what happens. And when oxygen desaturates, the masseters kick in immediately. Wow. And within nanoseconds, all the other masticatory muscles kick in because we need to move that jaw out of the way.
To get air.
And it's those muscles which will do it. Bruxism now, we identify it with airway issues and occlusal issues. But the airway issue is huge. Your occlusion could be perfect, but if your airway is collapsible, you're still going to clench and grind to open up that airway.
And that's kind of what leads into, if you say you do have great occlusion and you've got well-developed jaws and your airway is still collapsible, that's where, myofunctional training comes in, because you could have volume. Volume's not necessarily just what we need. We need strength in those muscles surrounding that whole place. So
it's very deceiving to take a CBCT scan, for example, and say, wow, look at that garden hose.
Looks great.
Isn't that beautiful?
Right.
A lot of different factors there. It's pretty complicated because it's not a matter of what we see structurally.
Yeah.
It really is a matter of whether or not it's collapsible.
Right.
So when you look at the airway, the nasal passages are rigid and the laryngopharynx down here is rigid. Mm-hmm. The collapsibility happens all in here.
Yeah.
So from the soft palate down, what's going on? And we can have a very narrow airway that's not collapsible and no problems, no symptoms. Why would you touch that person? We can have a giant airway, and unfortunately, it very, very much is collapsible.
Yeah.
So that myofunctional therapy alone has been shown to reduce symptoms of potential airway issues by up to 50%. So that is the issue. It's the collapsibility of the middle portion of the airway that is usually the biggest problem.
Yep.
Structurally, if there's deviation from a broken nose, from a deviated septum that happened developmentally, from infections that are chronic, so look for all those upper wisdom teeth that had root canals that may be chronically infected, that affects the sinus membrane in terms of what's going on with all of that. Those are typically what we wind up seeing.
Now, putting braces on somebody with an already narrow palate and long face characteristics, are those individuals almost better off just leaving their crooked teeth if there's not any funds to go through the extensive, more complex orthodontic needs instead of having, let's just straighten your teeth and do retractive dentistry? Or
So bear in mind that any kind of orthodontic, well, let's go back.
okay.
When a child walks in the door, what we're looking for is, are they mouth breathing? And
Yeah.
then if they're mouth breathing, we know what we're going to find inside. Neutral zone is where our teeth wind up because of the muscles of the inside going out and the outside going in. Okay? So we were talking a lot about the tongue.
Right.
The tongue can generate 500 grams of force. That's why it's such an incredible muscle to grow the midface. Your lips and your cheeks can generate about 300 grams of force. So the teeth wind up where they wind up because of this balance between the outside and the inside. Right? So now if your tongue is tied to the floor of the mouth, which muscles are working?
Your lips.
They're coming in, collapsing things, right?
Right.
If your tongue is not able to swallow properly, a swallow should be invisible in a child, in anybody. A swallow should be invisible. When we do this, we recruit facial muscles in order to be able to swallow.
Right.
And that puts more force, that mentalis strain, crowding those lower teeth, the tongue tie, retroclined or tipped back as far as those teeth. But bear in mind that if the tongue is not up here, the teeth collapse. So when we're collapsing in, now we've lost more room for the tongue. The mouth is the garage for the tongue. The smaller we make the garage, when we close the door, that tongue can only go in one direction, and that's back. So now if the tongue generates 500 grams of force, the lips and cheeks generate 300 grams of force, those teeth are going to find wherever that balance is between the muscles by coming in and collapsing towards the weakest muscle.
Right.
So neutral zone is always where the teeth end up because of that equilibrium. Exactly. So when I have a patient come in for Invisalign, when I have a patient come in for any kind of orthodontic, we need to make sure that the tongue is available to do what it needs to do. So if there's any issue with that, tongue releases and myofunctional therapy. And the myofunctional therapy is what's going to make that tongue strong and what's going to make retention much more predictable long term. And most kids that go through braces, they start at 13, 14, the worst years in the world to get a kid to do anything.
Right.
They go through 2-3 years of braces, and finally the orthodontist says, well, your kids are not compliant.
Shocking.
And the parents say, well, what are you talking about? They do this. Everybody's done. Throw in the hat. We're finished. Retainers go in. They're usually lost within the first 2 to 3 months. Everything relapses. Everybody's angry. Except for the kid.
If you had to give one piece of advice to a mother who's identifying a child with, say, sleep disordered breathing, because it's not very common. If you go to a general doctor, a general dentist, a pediatrician, they're not jumping on it. A lot of the times they're saying, oh, they'll grow out of it. That's common to see. I mean, I've said that in the past before I knew about all of this. So about a mother that's seeking a little bit more guidance with that, what would you recommend for her?
So my first questions are always, does your child snore, or can you hear them breathing? So labored breathing is airway resistance, and snoring is a huge red flag no matter what age, but especially in children. Okay, so breathing should be silent. Parents need to go in and check on their children at nighttime. And whatever habits we tend to have during the day, mouth breathing, we're going to have at nighttime. So breathing becomes a behavior. All right. And if we can correct that behavior during the day, there's going to be much better improvement in correcting these habits, so that while we're sleeping, you're going to see improvement there as well. You've got to be able to see it both ways. So snoring and breathing, labored breathing is huge. The rate of breathing is huge. In an ideal situation, if we were living an optimal health life, the breathing rate should be about between 6 and 8 breaths per minute. And most children in our society are breathing at somewhere between 20 and 24 breaths per minute. If we're breathing through the nose and we breathe too rapidly, there's more resistance. So guess where there's less resistance? Open mouth. So it should be slow breathing. It should be silent breathing. The other thing about breathing is that, again, it'll dry out the tissues if you're breathing through your mouth. Tonsils and adenoids will swell and become inflamed. Now, there's another obstruction. Breathing too rapidly, you blow off too much carbon dioxide. And as far as the physiology and the chemistry behind breathing, carbon dioxide is what tells your body when you need to breathe next, not your lack of oxygen. You could have 100% oxygen saturation in your bloodstream. If your carbon dioxide level is not where it should be, you're not going to exchange the gases. And what controls that or contributes to that control is the nitric oxide. So again, it's those three gases which are absolutely essential for gaseous exchange. And if you don't breathe through your nose, you don't get nitric oxide. About 90% of the nitric oxide is made in the paranasal sinuses. The other 10% is in the gut. Gut has a lot to do with our immune system. That gut-brain connection has a lot to do with our immune system. But let's go to the gut. If you don't nasally breathe and you mouth breathe, you're using your chest muscles to mouth breathe.
Right.
Your posture changes. Head forward. Every inch that your head comes off the spine adds 10 pounds to the weight of your head. That's why we developed a hump on the back. Yeah. That's why we get constricted and we can't ventilate properly. The fact that we don't use the diaphragm when we breathe through the mouth makes the visceral organs kind of stagnant. So we think that people who suffer from IBS, Crohn's disease, all those things could be from having a stagnant midsection core that's not being massaged, that's not allowing for flow. And so, to me, it makes all the sense in the world physiologically. Yeah. And it could, listen, it's all anecdotal. Mm-hmm. But those people who suffer from the IBS and the Crohn's and so on, I guarantee you there's a contributing airway issue there. I guarantee you they're not exchanging gases properly. And that's contributing to the stagnant gut and leaky gut syndrome and failure to thrive and all of these things that are so everything common. We suffer from as a society is a degenerative inflammatory disease. And again, we need to look at what causes inflammation. The bacteria between our teeth. Mm-hmm. So you know as well as I do. Absolutely. Flossing adds 10 years to your life. Yeah. Getting rid of all the crap in our food can make a huge difference if we clean that up, because that's inflammation. Okay. And then in terms of, again, just basically being able to breathe properly as a proper behavior and having that proper gas exchange is what allows us to thrive.
It's amazing. It's so simple, but so hard to achieve in one individual life sometimes.
Well, because of the way that our society has evolved, I always told my children, convenience kills. So whether that be with fast food, whatever it may be, convenience kills. Yeah. I'm not a believer in, again, frozen meals and so on. I know people do what they do for different reasons. Sure. But when you start to put this all together, and especially what we're living through now, I think is going to wake up a lot of people to what are they doing to us in terms of food additives. Yeah. So you have to decide what you're going to do or not do for your own health, for your family, for your loved ones.
I run into it where I'm educating or trying to educate my patient just on, the simple basis of breathing through your nose and like not even going into how that is related to dentistry, but to overall health. But it's interesting, even talking to parents, it's some parents want to see it and some parents or people don't want to see it. So you can do this to prevent all of these things, or you can just not. And then you'll see where the chips fall.
I think with all of this stuff, I think with TMJ, I think with occlusion, which, we understand and know the benefits of not having the dentition break down. Yeah. Because the more teeth you lose, the less neural connection there is between your jaws and your brain. Mm-hmm. And your teeth, although they're not bones, they're part of your skeletal system. Yeah. that when you lose teeth or teeth are not in the right place and it changes that alignment,
Yep.
it has to do with your entire alignment,
Yeah.
full body.
Yeah.
So, you know what, doc, it's a second molar, get rid of it. Again, but educating people so they understand what we're trying to share with them. And yes, then you make the decision, and parents don't want to hear there's something wrong with your child
Oh gosh,
or your
never.
child's face is not developing properly. What are you talking about? They're beautiful.
Right.
Yes, they are. But you know what? You introduce this stuff, you let them know about it. The reason, again, why we put the book together that I have in my office that at this point we try to share with everyone in terms of having it as a tool to say, well, here's a list of things that we normally ask parents to see if they identify in their children and have them co-diagnose it with us.
Yeah.
And if a parent says, well, what are you talking about? Okay, maybe they're not ready.
Sure.
But if you introduce them to it and they then go home and start to observe and then they call back and say, hey, you know what? You're right. I see him all the time or her all the time and she's walking around with her mouth wide open. And it doesn't have to be a wide open mouth. If the lips don't come together, they're not nasally breathing.
No, your body wants oxygen from the biggest hole.
So a lot of observation there as far as how they're eating, how they're swallowing, how they're speaking. It's all connected physiologically. Yeah. And those are the things that, again, they should be looking for.
Yeah, definitely. So tell me a little bit more about your book as far as like where could somebody go to get their hands on a copy?
So the book actually came to be because as I'm not lacking in conversational words, there's a gentleman, you might have picked up on that. There's a gentleman who has helped me with my marketing. His name is Mark Curtis, and the Curtis Marketing Group has actually helped me tremendously with regards to getting all the different graphics and animations and so on put together. The more I explained what was going on, the more we kind of put our heads together and said, what do you think about this? So it actually took us a little over 2 years, almost 2.5 years to put that together.
Wow, that long.
And if anybody is interested, we've done a video that can go in the treatment room, in the reception area.
Excellent.
There's a video that's a little more expanded if someone wants to, see more information if they don't want to read.
Sure.
It's very graphic, as you know. It's more of a pictorial guide for that. Again, I owe a lot to Mark for helping me really organize that. And so it's Curtis Marketing Group. That's out in Minnesota.
Okay.
And they're basically just look them up on Google and speak to Mark directly. And he really is the one who's been distributing them to different dentists throughout the country who have seen it and have expressed an interest. So.
Okay. Would a non-dental professional be able to get a copy of that by calling them as well?
Good question. I think it's more, again, in terms of what we're looking to do is to have it in the office so that people can get a copy of it from their dental professional.
Yeah.
But you know what? I will ask Mark if there's a way to do that.
Yeah.
And if you have enough interest in your group, that you're doing this for, I will definitely see what we can do to make that available. Yeah, by all means.
Address
so you let me know.
Yeah.
Yep, you let me know, and we'll see what we can do about making sure that that's available.
All right. Well, thank you so much, Dr. Gaudio. This has been so much fun and educational as always. You're just so knowledgeable. So I appreciate you taking the time and talking with me here.
My pleasure. My pleasure. Thank you.